The person at risk for an ACL is usually an athlete who is involved in a sport that requires a twisting type motion, or an athlete involved in a sport where there's contact. With that being said, anybody can tear the ACL. If someone walking down the street who sustains a twisting injury, maybe steps off the curb and lands funny, or steps in a hole, that type of twisting motion could make that person susceptible to an injury. The ACL is a somewhat unique ligament in that it is inside the knee joint. And for that reason, it's not necessarily very susceptible to injury, as much as when it is injured, it does not heal. And because it does not heal, it requires treatment in many cases, and for that reason, it is a ligament that is spoken about a lot. When a patient presents with a knee injury and possibly a torn ACL, the most important first thing is a good physical exam and a good history. Usually the history will be one of the knee being twisted, the patient experiencing or feeling a pop sensation, difficult weight bearing with a feeling of looseness in the knee. On initial physical exam, there's usually some restriction of motion. There is usually a fair amount of swelling in the knee, and the knee will feel loose on exam, and an experienced examiner is usually able to ascertain some looseness in the knee. The initial treatment at that time involves protected weight bearing, trying to help the patient regain their motion, and using other mechanisms to try to decrease the swelling of the knee. At that time, usually an MRI is undertaken. An MRI is a computerized magnetic study, which is a very good way of evaluating whether there is not an ACL tear. When it's been determined that a patient has an ACL tear, a decision has to be made on whether the patient is a candidate for ACL reconstruction. In general, a young, active person who has a confirmed ACL tear with instability should have the ACL reconstructed. Conversely, an older, less active person whose knee is relatively stable may not need the procedure. If the patient chooses not to have an ACL reconstruction, that patient is at risk for instability when performing certain activities, and is also at risk for doing further damage to the knee with instability events. The menisci, which are the cartilages in the knee, and the joint surface can be damaged with recurrent instability. When the patient has decided to have an ACL reconstruction, the ACL ligament needs to be replaced with another tissue. The two types of grafts that are most commonly used are: one, autograft, which is the patient's own tissue, and two, allograft, which is a cadaver graft. The procedure is done arthroscopically, which means a camera is inserted into the joint with small incisions. The knee is insufflated with saline, which allows the surgeon to see the inside of the joint. And then the graft is placed in hopefully the exact position where the native ACL ligament had been prior to injury. In the 21st century, almost all ACL reconstructions are done arthroscopically. It is actually easier to do it in this way with smaller incisions, and actually the arthroscope allows you to see parts of the knee joint that cannot be seen with an open repair. For that reason, in these times, most ACL reconstructions are arthroscopic. The post-op process for a patient who undergoes ACL reconstruction is usually a 6-month process. Initially, the patient is on crutches for a few weeks, and during that time, the patient gets their motion back and is able then to eventually place weight onto the leg, and usually after a few weeks is relatively comfortable. After that, the patient has several months of a rigorous physical therapy program to enable them to regain their full strength and to regain the full motion and strength of the knee. Usually after a 6-month period of time, most patients are back to their relatively normal activities, and the ACL reconstruction is successful in greater than 90% of the time in getting patients back to their normal activities.